This video will cover acute rheumatic fever, rheumatic heart disease, based on Nelson's textbook of Pediatrics and other current guidelines. Our learning objectives include understanding the epidemiology of ARF and RHD, explaining the pathogenesis, and applying the 2015 AHA revised Jones criteria. We will also identify clinical manifestations, interpret lab and echo findings, outline prophylaxis regimens, and recognize surgical indications. Finally, we'll discuss updates from current WHO and Australian guidelines. Acute rheumatic fever, or ARF, is a non-suppurative autoimmune complication of Group A streptococcal pharyngeal infection. It leads to a combination of manifestations like arthritis, carditis, subcutaneous nodules, erythema marginatum, and chorea. Rheumatic heart disease, or RHD, is the chronic structural change in heart valves, typically affecting the mitral valve, after one or more episodes of ARF. Globally, RHD affects over 39 million people and causes 300,000 deaths annually. ARF incidence ranges from 8 to 51 per 100,000. Peak age is 5 to 15 years, with the highest incidence in specific populations like Indigenous Australians and Sub-Saharan Africans. The recurrence rate of ARF can be up to 50%. Risk factors for ARF include host and social factors like age 5 to 15, crowding, poor socioeconomic status, and family history. Infectious and genetic factors include a prior episode of ARF, which is the strongest risk factor, untreated gas pharyngitis, rheumatogenic M protein serotypes, and certain HLA associations. The causative agent is Group A streptococcus. ARF is a delayed autoimmune sequela of gas pharyngitis. Molecular mimicry is key, where gas M protein and carbohydrate antigens cross-react with human cardiac and neuronal tissues. The response is T-cell mediated, leading to inflammation and damage. Genetic susceptibility is linked to HLA class II alleles DR7 and DR4. The pathogenesis pathway starts with gas pharyngitis and M protein exposure, leading to immune activation, cross-reactive antibodies via molecular mimicry, and widespread tissue inflammation. This ultimately causes valve damage and fibrosis, known as RHD. Recurrent infections reduce immune tolerance and increase the risk of progressive valvular damage. Now we transition to the clinical manifestations, which are classified using the major and minor criteria of acute rheumatic fever. The Jones criteria, revised in 2015, diagnose initial ARF with either 2 major or 1 major and 2 minor manifestations, plus evidence of preceding gas infection. For recurrent ARF, the requirements are 2 major, 1 major, and 2 minor or 3 minor manifestations, along with evidence of gas infection. Subclinical carditis is now a major criteria. In low-risk populations, major criteria include carditis, polyarthritis only, chorea, erythema marginatum, and subcutaneous nodules. Minor criteria are prolonged PR interval, polyarthralgia, fever, and elevated ESR or CRP. For moderate to high-risk populations, the major criteria are the same, but the joint criteria include monoarthritis or polyarthritis, and polyarthralgia after excluding other causes. Minor criteria are monoarthralgia, fever, and elevated ESR or CRP. The definitions vary by population risk status. Carditis is the most serious manifestation, affecting 50 to 70% of first episodes, often presenting as pancarditis. Valvulitis, typically affecting the mitral valve, is the hallmark, often resulting in new murmurs like apical pansystolic or early diastolic murmurs. Subclinical carditis, detected by echocardiography, is now a major criterion, and Doppler echo is recommended in all suspected ARF cases. Arthritis is the most common major manifestation, seen in up to 75% of cases. It presents as exquisitely painful, migratory polyarthritis in large joints. A dramatic response to anti-inflammatory therapy within 24 to 48 hours is characteristic. In high-risk groups, monoarthritis and polyarthralgia are now major criteria, but arthralgia cannot be a minor criterion if arthritis is a major one. Sydenham chorea, or St. Vitus dance, presents as involuntary, purposeless movements, often appearing late. It may be the sole manifestation of ARF. It's linked to antineuronal antibodies cross-reacting with basal ganglia. Clinical signs include milkmaid grip and darting tongue. It is self-limiting and may not require evidence of preceding gas infection. Skin manifestations are uncommon. Erythema marginatum appears as pink macules with central clearing, non-pruritic, and can be elicited by a warm bath. Subcutaneous nodules are firm, painless nodules, typically found over bony prominences. They are associated with severe carditis and usually appear weeks after other symptoms. We now move to the diagnosis and investigations for acute rheumatic fever, focusing on laboratory workup and echocardiography. An essential requirement for ARF diagnosis is evidence of preceding group A strep infection, except for isolated chorea or indolent carditis. Serological tests like ASO and anti-DNase B titers are most reliable. Throat culture is the gold standard for current gas detection, but may be negative post-infection. Key laboratory findings in ARF include elevated ESR and CRP, which are essential markers of inflammation. CRP rises and falls faster than ESR, making it useful for monitoring. CBC may show leukocytosis and anemia. ECG can show a prolonged PR interval, a minor criterion. Echocardiography is essential for detecting valvular regurgitation and morphological changes, a necessary investigation in all suspected ARF cases. The World Heart Federation updated the echocardiographic criteria for RHD diagnosis in 2023. These new criteria introduce simplified screening and detailed confirmatory criteria, as well as a new stage-based classification to stratify risk. The table details criteria for definite RHD and borderline RHD, focusing on pathological regurgitation and morphological changes of the mitral and aortic valves. The differential diagnosis for ARF includes several conditions grouped into autoimmune, inflammatory/infectious, and other categories. Autoimmune conditions include juvenile idiopathic arthritis and systemic lupus erythematosus. Infectious causes include infective endocarditis and septic arthritis. Other diagnoses include Kawasaki disease and leukemia/lymphoma. Next, we will discuss the management of acute rheumatic fever, covering anti-inflammatory therapy, gas eradication, and supportive care. Anti-inflammatory treatment is directed by the presence and severity of carditis and arthritis. NSAIDs or aspirin are used for arthritis without carditis. Prednisolone is indicated for moderate to severe carditis to suppress inflammation and reduce the risk of RHD progression. Treatment for chorea involves supportive care and medications like valproate or carbamazepine, as anti-inflammatory agents are ineffective. The goal of gas eradication is to eliminate any residual infection at the time of ARF diagnosis, regardless of throat culture status. A single dose of benzathine penicillin G intramuscularly is the regimen of choice. Alternatives, such as oral penicillin V, can be used. We now turn our attention to prevention, which involves both primary prevention and secondary prophylaxis. Primary prevention aims to prevent the first episode of ARF by promptly treating gasopharyngitis, ideally within 9 days of symptom onset. Benzathine penicillin G is the only agent specifically studied for ARF prevention. Primordial prevention addresses social determinants like overcrowding and poor sanitation. Currently, no effective gas vaccine is available. Secondary prophylaxis is crucial for preventing recurrent gas infections and subsequent ARF episodes, thus preventing or slowing RHD progression. Benzathine penicillin G intramuscularly every 3 to 4 weeks is the preferred and most effective regimen. Adherence is a major challenge globally. The duration of secondary prophylaxis varies based on the patient's cardiac status. It ranges from 5 years after the last ARF episode, to age 21 for ARF without carditis, to 10 years or age 40 for ARF with RHD. Lifelong prophylaxis is recommended for patients with severe RHD or post-valve surgery. Regular echocardiography helps guide duration decisions. Finally, we discuss the management of established rheumatic heart disease, focusing on medical optimization and surgical intervention. Medical management includes continuing secondary prophylaxis, which is the most important step to prevent progression. Treatment also addresses heart failure and atrial fibrillation. Infective endocarditis prophylaxis is only recommended for high-risk procedures in patients with prosthetic valves or prior IE. Surgical management is indicated for severe symptomatic valve lesions or progressive heart dysfunction. Options include mitral valve repair, which is preferred when feasible, or valve replacement. Percutaneous valvuloplasty is an option for suitable mitral stenosis. A major challenge is limited surgical capacity in high-burden regions. The prognosis primarily depends on the severity of cardiac involvement during the initial episode. Patients without carditis have an excellent prognosis. Those with mild carditis have a good outlook with adequate secondary prophylaxis. However, moderate to severe carditis carries a risk of progressive damage despite prophylaxis. Recurrent episodes significantly increase the risk of chronic RHD. Key takeaways include that ARF is a preventable autoimmune sequel to gasopharyngitis. The 2015 Jones criteria now account for population risk. Carditis is the only permanent manifestation, making early echocardiography essential. Secondary prophylaxis is the cornerstone of RHD prevention, and addressing social determinants is critical for primordial prevention. These are the references used for this video, including Nelson's Textbook of Pediatrics, AHA, WHO, and Australian guidelines, and recent literature on echocardiography and management. Thank you for watching this video on acute rheumatic fever and rheumatic heart disease.